Okay, so I'll let you then do the slide movement for me. Thank you so much. So I'm just going to talk about two different things, thromboprophylaxis and bleeding tendency during COVID presentation. Next, please. And then quickly to the next, please. So thank you. In COVID-19, there's significant increased risk of hospital-associated venous thromboembolism. There are also other types of thromboembolism, arterial types, but I'm going to focus more on the venous side because it's more common. This is predominantly due to excessive inflammatory response during the acute phase reaction, combined with immobility and the vascular changes that takes place during this event. Lung injury in particular will lead to hypoxia, which also can trigger thromboembolic cascade. This is usually associated with significant DIC, but in COVID presentations, the platelet drop is not parallel to the increase in coagulopathy protein. Next, please. So really, it remains unclear what is the exact prophylaxis that is recommended at this stage because we still don't know a lot. Whether we use a standardized prophylaxis that we use for other patients, or do we use a D-dimer scoring system? Imperial College have came up with a good actually recommendation, which I will come up with later. High D-dimer certainly and high fibrinogen degradation products are markers for worse prognosis. Next, please. So Thrombosis UK group, which basically have come up with certain recommendations, and basically when patients have creatinine clearance of more than 30, they suggested you could use either low molecular weight heparin or fondaparinux. But if creatinine clearance is less than 30, but obviously there's limitations. If it is less than 15, then you can't use low molecular weight heparin. But if it is generally less than 30, you can use unfractionated heparin subcutaneously twice a day or 3 times a day, depending on the clinician's discretion. Patients who present to hospital with pre-existing anticoagulation on board, like those with atrial fibrillation or more difficult valvular metallic prosthesis, who are already on either warfarin and those atrial fibrillation who are taking NOACs, they should switch straight away to low molecular weight heparin once they are admitted with a COVID presentation. Abnormal coagulation results that we see on day-to-day practice do not necessarily require any correction if the patient is not bleeding. So they just need monitoring. There will be a lot of changes on the APTTs and PTs without necessarily bleeding. So that has to be managed very, very carefully. A lot of times hematologists will say they would need to assess every patient individually, but there will be a background recommendation for anticoagulation. In our hospital and University Hospital Limerick, at the moment, we are only giving standardized, usual low molecular weight heparin prophylaxis. But the general feeling is that is not enough. And the general feeling is it is somewhere between the standardized prophylactic dose and the therapeutic dose. Now, some patients present with a clear-cut venous thromboembolism, or like PE, for example. Those ones obviously will have to be on high doses, therapeutic low molecular weight heparin. One of the difficulties that we face in COVID patients in terms of anticoagulation, there's a significant proportion that are heparin resistant. So even if you give them high doses of low molecular weight heparin, they may not actually respond. And I have a nice slide at the end to show one of the graphs reflecting that resistance. Next, please. This is a way of generally trying to dose patients who need to go on low molecular weight heparin or even unfractionated heparin, depending on the weight and their creatinine clearance. Obviously, if patients have significant renal impairment, you can only use unfractionated heparin. And in some cases, if patients are severely underweight, below the 50 kilo mark, then it has to be obviously closely discussed with hematology. Next, please. This is the Imperial College. I like this slide actually quite a lot because it's simple and it is very practical. And it divides patients according to their weight and their D-dimer score. As we know, D-dimer, high D-dimers would give higher and worse prognosis, and therefore the dose of heparin will be dependent on the D-dimer. It has to be relevant to the D-dimer level. So this is a good guidance. I think we should all have this table if we are managing patients with thromboembolism during COVID era. Next, please. This is again another slide to give us a quick risk stratification for those with COVID pneumonia of the risk basically when if they get DIC, depending on their platelet count, the dimer level, fibrinogen product, fibrinogen level, and the PT prolongation. So it gives a certain score, and those with over 5, they may have overt DIC, which is obviously a significantly prognostic marker. Next, please. This is the slide I was talking about. TEG is one of those point of care tests that hematology use sometimes. And it's there are kind of multiple tests. It's very difficult to interpret this, but there are multiple tests to determine the coagulability state of the patient, and they plotted against the level of anticoagulation. So as you can see on the top line, the anticoagulation levels remain at adequate dose, which is the higher line, while the coagulation of the patient remains quite significant despite the available doses of enoxaparin. Next, please. I move on to the bleeding side because it's also one of the problems during COVID, especially at the later stage. Initially, thrombosis appears, and then as the inflammation continues, vessel becomes more permeable and they leak more fluid and blood. So bleeding risk significantly increase as the days move on during COVID infection. So generally minor bleeding, we recommend, or the recommendation from the societies to monitor their FBC and the coagulation screen without necessarily interfering. And next, please. And if there's any major bleeding, they recommend early fresh frozen plasma. That's very important because if you prevent bleeding early, you could prevent significant problems, because once bleeding is established, it's difficult to come back from that. So FFP, early FFP is the best way forward. Platelet count, only platelet transfusion if the platelet count is below 50. There's no real evidence if it is above 70 or around 70, trying to push it even more. Fibrinogen replacement is really reserved sometimes for those who received FFP, but they still have bleeding. They have to be guided by the fibrinogen level. Now, it's very important to remember tranexamic acid should not be given for COVID patients who have DIC. It's absolute contraindication. And rarely they give recombinant factor 7A. Next, please. And that's it. So very brief. Thank you.